evening, good morning, and good afternoon to all my friends and viewers. Welcome to my live stream. Welcome to my YouTube channel. And I would like to continue my topic about health assessment in nursing. And under health assessment in nursing, the continuations of anus and prostate assessment. Okay, physical assessment procedure, anus and rectum inspection. Inspect the perineal area. Assessment procedure is spread the client's buttocks and inspect the anal opening and surrounding area. Figure 23-4 for the following. Number 1, lumps. 2, ulcer. 3, lesions. 4, rashes. 5, redness. 6, fissures. Lastly, thickening of the epithelium. Shout out to senior citizen Lucy TV. Good evening po and Merry Christmas. The anal of normal findings should appear hairless, moist and tightly closed. The skin around the anal opening is more coarse and more darkly pigmented. The surrounding perineal area should be free of redness, lumps, ulcer, lesions and rashes. Abnormal findings. Lesion may indicate sexual transmitted disease, cancer, or hemorrhoids. Shout out to Salve Malaya. Gandang gabi po. Merry Christmas. Good evening. A thrombus external hemorrhoids appear swollen. It is itchy, painful, and bleeds when the client passes through. Previously, thrombus hemorrhoids appears as a skin tag that protrude from the anus. A painful mass that is hardened and reddened suggested a perineal abscess. A swollen skin tag on the anal margin may indicate a fissure in the anal canal. Redness and the echorations may be formed, scratching an area infected by fungi and pinworms. A small open in the skin surrounds the anal opening, may be anorectal fistula. Abnormal findings 23-1. Ask the client to perform a Valsalva maneuver by straining or bearing down. Inspect the anal opening for any bulges or lesions. Normal findings, no bulging or lesions appear. Abnormal findings, thickening of the epithelium, suggests repeated trauma from anal intercourse. Senior citizen Lucy TV. Hello, Salve Filipino Story. Inspect the sacrococcygeal area. Assessment procedure. Inspect this area for any signs of swelling, redness, dimpling, or hair. Normal findings, area is normally smooth and free of redness and hair. Abnormal findings, a red and swollen or dimple area covered by small stub of hair located midline on the lower sacrum, suggests of pilonidal cyst. See abnormal findings 23-1. Sato to Juanita Peralta. Good evening po. Merry Christmas. Thank you for coming to my live stream. Yes po. Palpation. Palpate the anus. Assessment procedure. Inform the client that you are going to perform the internal examination. At this point, explain that it may feel like his or bowels are going to move, but that this will not happen. Lubricate your gloves in index finger. Ask the client to bear down. As the client bear down, place the fudge of your index finger on the anal opening. Senior Citizen Lu 7 TV. Hi, Juanita. Juanita Peralta. Hi, Nay. Clinical tip: never use your fingertip. This causes the sphincter to tighten and it force into the rectum, may cause pain. Normal findings: client sphincter relaxes, permitting entry. Abnormal findings: sphincter tightens, making further examination unrealistic. When you feel sphincter relax, insert your finger with the pad facing down, figure 23-5 and 23-6. Normal finding examination: finger enters anus. Abnormal findings: examination, finger cannot enter the anus. If the sphincter does not relax and the client reports severe pain, spread the gluteal folds with your hands and close approximations to the anus and attempt to visualize a lesion that may be causing the pain. If tension is maintained of the gluteal folds for 60 seconds, the anus will dilate normally. Normal finding: examination, finger enters anus. Abnormal finding: examination, finger cannot enter the anus. Clinical tip: if severe pain prevents your entrance to the anus, do not force the examination. So I will show you the picture, the 23-4, inspecting the perineal area. Alright. Ask the client to tighten the external sphincter. Note the tone, the assessment procedure. Normal findings: the client can normally close the sphincter around the gloved fingers. Abnormal findings: poor sphincter tone may be the result of the spinal cord injury, previous surgery, trauma, or prolapse. Rectum: tightened sphincter tone may indicate anxiety, scarring, or inflammation. Rotate finger to examine the muscular anal ring. Palpate the tenderness, nodules, and hardness. Assessment procedure: normal findings: the anus is normally smooth, non-tender, and free of nodules and hardness. Abnormal findings: tenderness may be indicate hemorrhoids, fistula, or fissure. Nodules may indicate polyps or cancer. Hardness may indicate scarring or cancer. Palpate the rectum. Assessment procedure: insert your finger further into the rectum as far as possible. Figure 23-7. Next, turn your hands clockwise, then counterclockwise. This allows you palpations as much rectal surface as possible. No tenderness, irregularities, nodules, and hardness. Normal findings: the rectal mucosa is normally soft, smooth, non-tender, and free of nodules. Abnormal findings: hardness and irregularities may be formed. Scarring or cancer. Nodules may indicate polyps or cancer. See figure of abnormal findings 23-1. Palpate the peritoneal cavity. The assessment procedure: this area may be palpated in men above the prostate gland, in the area of the seminal vesicle, on the interior surface of the rectum. In women, this area may be palpated on the interior rectal surface, in the area of the recto-uterine pouch, behind the cervix and the uterus. No tenderness or nodules. Normal findings: this area is normally smooth and non-tender. Abnormal findings: peritoneal protrusions into the rectum called rectal shelf. See abnormal findings 23-1 may indicate a cancerous lesion or peritoneal metastasis. Tenderness may indicate peritoneal inflammation. Prostate gland. Palpation. In male clients, palpate the prostate. To assessment procedures, the prostate can be palpated on the interior surface of the rectum by turning the hand fully counterclockwise. So, fold your index finger face towards the client's umbilicus. Figure 23. The size tell the client that he may feel the urge to urinate but that he will not. Move the fold of your index finger over the prostate gland, trying to feel the sulcus between the lateral lobes. Note the size, shape, and consistency of the prostates and identify any nodules or tenderness. Clinical tip: you may need to move your body away from the client to achieve the proper angle for examination. Normal findings: the prostate is normally non-tender and rubbery. It has two lateral lobes that are divided by median sulcus. The lobes are normally smooth, 2.5 cm long and heart-shaped. Identify any tenderness with examination or nodules palpable. Abnormal findings: a swollen tender prostate may indicate acute prostatitis. An enlarged, smooth, firm, slightly elastic prostate that may not have median sulcus suggests benign prostatic hypertrophy, BPH. A hard area of the prostate or hard fixed in irregular nodules on the prostate suggests cancer. Abnormal findings 23-2. Clinical tip: you may need to move your body away from the clients to achieve the proper angle for examinations. Check stool. Inspect the stool. Assessment procedure: withdraw your gloves. Finger inspect any fecal matters on your glove. Assess the color and test the feces for occult blood. Provide the client with towel to wipe the anorectal area. Normal findings: stool is normally semi-solid brown and free of blood. Abnormal findings: black stool may indicate upper gastrointestinal bleeding. Gray or tan stool result from the lack of bile pigment, and yellow stool suggests steatorrhea, increased fat content. Blood detected in the stool may indicate cancer of the rectum or colon, and endoscopic examinations of the colon should be performed. So, I will show you the pictures of the 23-5 relaxing the anal inspector. Figure 23-6 palpating the anus. Figure 23-7 palpating the rectal wall. And figure 23-8 palpating the prostate gland. Alright. Now, abnormal findings. Abnormalities of the anus, and rectum. External hemorrhoids. Hemorrhoids are usually painless papules caused by a varicose vein. They can be internal or external, above or below the anorectal junction. This external hemorrhoids has become thrombose. It contains clotted blood. It's very painful and swollen, and it is and bleeds with bowels movement. Perineal abscess. Perennial abscess is a cavity of pus caused by infection in the skin around the anal opening. It causes throbbing pain and it's red, swollen, hard, and tender. Perennial abscess. Anal fissure. The split of the tissue of the anal canal are caused by trauma. A swollen skin tag, sentinel tag, is often present below the fissures on the anal margin. They cause intense pain, itching, and bleeding. Anorectal fistula. This is evidenced by a small round opening in the skin that surrounds the anal opening. It suggests an inflammatory tract from the anus or rectum out of the skin. A previous abscess may have preceded the fistula. Anal fissure, sentinel tag. Anorectal fistula. Rectal prolapse. This occurs when the mucosa of the rectum protrudes out through the anal opening. It may be involve only the mucosa or the mucosa and the rectal wall. It appears as red donut-like mass with a rating fold. Pilonidal cyst. This is congenital disorder. Is characterized by small dimple or cyst sinus that contains hair. It is located midline in the sacrococcygeal area and has palpable sinus tract. Rectal polyps. These substructures are rather common and occur varying size and number. There are two types of pedunculated on a stalk and sessile on the mucosal surface. Rectal cancer. A rectal carcinoma is usually asymptomatic until it is quite advanced. Thus, routine rectal palpation is essential. A cancer of the rectum may feel like a firm nodule, an ulcerated nodule with rolled edges, or it's grown as large, irregularly shaped, fixed, and hard nodule. Rectal polyps and rectal cancer. Rectal shape. If cancer metastasizes, the peritoneal cavity is may be felt as nodular, hard shape-like structure that protrudes onto the interior surface of the rectum in the area of the seminal vesicle in men and in the area of the rectouterine pouch in women. Rectal shape. Abnormalities of the prostate gland. Acute prostatitis. The prostate is swollen, tender, firm, and warm to the touch. Prostatitis is caused by bacterial infection. Swelling, inflammation, characterized of acute prostatitis. Benign prostatic hypertrophy. The prostate is enlarged, smooth, firm, and slightly elastic. The median sulcus may not be palpable. It is common men older than age 50 years. Swelling, inflammation, characteristic of acute prostatitis. Enlargement, characteristic of benign prostatic hypertrophy. Mass characteristics of prostate cancer. Cancer of the prostate, a hard area of the prostate or hard, fixed irregular nodule of the prostate suggests cancer. Median sulcus may not be palpable. Thank you po, Senior Citizen Lucy TV. Still, salamat po. Thank you. Validating and documenting findings. Validate the anus, rectum, and prostate assessment data you have collected. This is necessarily to verify the data are reliable and accurate. Documents the assessments data following the health care facility or agency policy. Sample of documentation. A 52 years old client reports no recent change in bowel patterns, no constipation, diarrhea, or blood in stool. He has no trouble controlling his bowels and denies pain and itching in anal area. He has no history of anal or rectal surgery or trauma and no congenital deformities. He states that his last DRE test for a cold blood and PSA screening were 1 year ago. No significant findings were reported. He said he had a sigmoidoscopic examination 2 years ago, and the results were normal. He has no knowledge of polyps or cancer. Colon, recta, or prostate. In his family, the client explains that he seldom uses laxatives and he has never used an enema. He denies engaging in anal sexual intercourse. He does not know exactly how much water and bulk he consumed but guessed a moderate to high amount. Sample of documentation of objective data. Client's anal opening is hairless, moist, and closed tightly. Perineal area is free of redness, lumps, ulcers, lesions, and rashes. No bulging or lesions appear when sacrosigil when client perform Valsalva maneuvers. The sacrococcygeal area is smooth, free redness and hair. Client can close internal sphincter around glove fingers. Anus is small, tender nodules and hardness. Rectal mucosa is soft, smooth, non-tender, and free of nodules. Peritoneal cavity area is smooth and non-tender. Prostate gland palpated as too smooth. Non-tender rubbery lobes are approximately 2.5 centimeter long. The median sulcus is palpated between the two lobes. After you collected the assessment data, you will need to analyze the data using diagnosis reasoning skill. Analysis of data, diagnosis reasoning, possible conclusion. After collecting subjective and objective information pertaining to the anus, rectum, and prostate, identify abnormal findings and client's strengths. Then cluster the data to reveal significant patterns or abnormalities. This data may be used to make clinical judgments about the status of the client's anal, rectal, and prostatic health. Selected nursing diagnosis. Following is listings of selected nursing diagnosis, wellness, risk, or actual that you may identify when analyzing the Q cluster. Well diagnosis. Number 1, readiness for enhanced bowel elimination pattern. 2, health-seeking behavior request information on purpose and needed for colorectal examination. Actual diagnosis. Number 1, risk diagnosis. Number 1, risk for ineffective health maintenance related to lack of knowledge of needs for recommended colorectal and prostate examination. 2, risk for impaired skin integrity in rectal area related to chronic irritations secondary to diarrhea. Actual diagnosis: 1. Acute faint rectal. 2. Diarrhea related to chronic inflammatory bowel disease. 3. Ineffective sexuality further related to feeling or loss or femininity, masculinity, and sexual attractiveness secondary to chronic diarrhea or faint. And lastly, situational low self-esteem related to loss of control over bowel elimination. Selected collaborative problem. After grouping the data, certain collaborative problem may become apparent. Remember, collaborative problem differ from nursing diagnosis is that the key as in that they cannot be prevented by nursing intervention. However, the nurse can detect and monitor this physiologic complication of medical conditions. In addition, physician and nurse prescribed interventions can be implemented to minimize this complication. The nurse may also have to refer the client in such situation for treatment of the problem. Following is a list collaborative problem that may be identified when assessing the anus, rectum, and prostate. These problems are worded as potential complication or PC followed by the problem. PC means potential complication. So number 1, prostatic hypertrophy. 2, fistula. 3, PC fissure. 4, PC hemorrhoids. 5, PC rectal bleeding. 6, PC rectal abscess. Medical problem, grouping data, the client's size and symptom, etc. Rectal prolapse and begins. The prostatic hypertrophy may require medical diagnosis and treatment. Referral for a primary care provider is necessary. The case study. The case study demonstrates how to analyze anus, rectum, and prostate assessment data for a specific client. The critical thinking exercises include in the study guide, laboratory manual, and interactive product that complement this text. This text also offer opportunity to analyze the assessment data. George Kowalski, 42 years old, seeks advice from the company nurse because he had been bleeding from his rectum and he has pain and pressure in the rectal area. Mr. Kowalski is the head accountant and tax consultant for the company. He is currently preparing for the annual audit and reports to the nurse that he is a very uptight. When questioned, he reports that he has observed a small amount of bright and red blood on his stool for the last 2 days, and his bowel movements have been quiet, painful, like passing ground glass for about the last week. His state has had hard bowels movements for many years. He refers drinking mostly coffee, 12 cups a day. He say his meals traditional eggs and bacon and breakfast and meat, potatoes for dinner. He doesn't much like vegetable and fruits. He doesn't eat excessively, and he has maintained his weight within the chart norms for over 20 years. He said he has used preparation H4 each piles for use with reliefs until lately when the anorectal area is inspected, several bluish rounded swelling are present external to the anal sphincter, and a small fissure is noted in the lining of the anus. A small amount of light red blood is visible near to the anal fissures. The following concept may illustrates the diagnostic reasoning process. Identifying abnormal findings and okay, this is the procedure again, the 7-step. Identify abnormal findings in client strength. Number 2, identify Q cluster. 3, draw inferences. 4, list possible nursing diagnosis. 5, check for defining characteristics. 6, confirm a rule out diagnosis. 7, document conclusion. That is the 7-step for the data of the patient. Okay, number 1, identify the abnormal findings in client strength, subjective data, bleeding from his rectum, faint and pressure in the rectal area, observed small amounts of bright red blood on his stool for the last 2 days. Bowel's movements have been quiet, painful, like passing ground glass for about the last week. Hard bowel movements for many years. Very appetite, preferring for annual adults, drinking 10 to 12 cups of coffee daily. Traditional eggs and bacon for breakfast, and meat and potatoes for dinner. He has maintained his weight within church norms for over 20 years. Used preparation age for relief for many years until recently. Identify cluster pain pressure in the rectal area. Observe the small amounts of bright red blood on his stool for the last 2 days. Bowel movements have been quiet, painful, like passing ground glass for about the last week. Hard bowel in movements for many years. Very appetite, preferring for annual adults. Use preparation age for many years. Relief until lately bluish rounded with swelling noted external to the anal sphincter. A small fissure in the lining of the anus. A small amount of light red blood visible near the anal fissure. Draw inferences. His history, the type of bleeding, bright light red and on the stool, and physical findings are suggestive of hemorrhoids, which the client has self-treated with OTC medication for some times. His bleeding and increased pain could be from the recent fissure on his tension, which may cause the inspector to tighten and possible cut off circulations to the external varices. Mr. K needs to be referred to his own physician for further works up regarding the bleeding and increased pain. Collaborative problems should also identify. Confirm because it meets the major and minor defining characteristic. Enter either or both may be confirmed because they meet the major defining characteristics. However, additional data must be collected to determine the correct cause of disorder to proper nursing order can be implemented. Let's proceed to the objective data. Bluish rounded swelling noted external the anal sphincter, a small fissure in the anal lining, a small amount of light red blood visible near the anal fissure. Identify Q cluster. Number 1, hard bowel movements for many years. Very tight up, preparing for annual audit. Drinks 10 to 12 cups of coffee daily. Traditional eggs and bacon for breakfast and meats and potatoes for dinner. Apparently, Mr. Kowalski has been living with a treating his bowel problem and is only sought assistance when he noted bleeding. His occupational stress and dietary habits tend to promote continuation of this problem. He does not indicate a desire to change his habit at this time. List possible nursing diagnosis. Constipation related to psychosomatic tension, improper diet and inadequate water intake to promote bowel health, major hard dry stool, painful defecation, minor rectal pressure, confirmed because it meets the major and minor defining characteristic, effective health maintenance related to insufficient knowledge of stress management and other health promoting behavior. Major demonstrate unhealthful practice and lifestyle, minor none. Ineffective health maintenance related lack of motivations, change lifestyle and not seeking treatment for chronic problem. Major demonstrates unhelpful practices and lifestyle, minor none. Document conclusion. Nursing diagnoses that are appropriate for these clients include constipation related to psychosomatic hypertension, and improper diet and inadequate water intake to promote bowel health. Ineffective health maintenance related to sufficient knowledge of stress management and other health promoting behavior. Ineffective health maintenance related to lack motivations to change lifestyle and not seeking treatment for chronic problem. Potential collaborative problem number 1. Again, PC means potential collaborative problem. Number 1, PC hemorrhage, PC varicella thrombosis, PC varicella strangulation. Mr. Kowalski should be referred to the physician for evaluation and treatment of rectal bleeding and pain. This is the end of my topic about anus, rectum, and prostate assessment. Now let's proceed to the next topic, musculoskeletal assessment. Structure and functions. The body of bones and joints compose the musculoskeletal system, controlled and innervated by the nervous system. The musculoskeletal system's overall purpose is to provide structure and movement for body parts. Bones. Bones provide structure, give protection, serve as levers, store calcium, and produce blood cells. 206 bones make up to the axial skeleton, head and trunk, and the appendicular skeleton, extremities, shoulders, and hips. Figure 24-1. Composed of osseous tissue, bones can be divided into two types: compact bone, which is hard to dense and make up the shaft and outer layers, and spongious bones, which means numerous spaces and make up the ends and centers of the bones. Bones tissue is formed by active cells called osteoblasts and broken down by cells referred to as osteoclasts. Bones contain red marrow that produces blood cells and yellow marrow composed mostly of fat. The periosteum covers the bones and contains osteoblasts and blood vessels that promote nourishment and formations of new bones. Tissue bones shape vary and include short bones, carpals, long bones, etc. Humerus, femur, flat bones, etc. Sternum, ribs, and bones with an irregular shape, etc. Hips, vertebrae. Skeletal muscle. The body consists of three types of muscle: skeletal, smooth, and cardiac. The musculoskeletal system is made up to 650 skeletal voluntarily muscle which are under conscious control. Figure 24-2. Made up of long muscle fibers, fasciculi that are arranged together in bundles and joined by a connective tissue. Skeletal muscle attached to bones by the way strong fibrous cords called tendons. Skeletal muscle assists with posture, produce body heat, and allow the body to move. Skeletal muscles movement illustrate in display 24-1 include abduction, moving away from the midline of the body; adduction, movement moving towards midline of the body; circumduction, circular motion; inversion, moving inward; inversion, moving outward; extension, straightening the extremity at the joint and increases the angle of the joint; flexion, bending the extremity of the joint and decreases the angle of the joint; pronation, turning or facing downward; supination, turning or facing upward; protractions, moving forwards; retractions, moving backward; rotation, turning heads to the right, shoulder then back the midline; next turning the heads to left, shoulder then back to midline. Joints. The joints or articulation is the place where two or more bones meet. Joints provides a variety of ranges of motion (ROM) for the body parts and may be classified as fibrous, cartilaginous, or synovial. Fibrous joints, sutures between skulls bones, are joined by fibrous connective tissue and are immovable. Cartilaginous joints. Joints between vertebrae are joined by by cartilage, synovial joints, shoulder, wrist, hips, knees, ankle. Figure 24-3 contain a space between the bones that is filled with synovial fluids, a lubricant that promotes a sliding movement of the ends of the bones. Figure 24 does one major bones of the skeletons. The axial skeleton is shown in yellow, the appendicular in blue. Cranium, facial bone, mandible, clavicle, scapula, humerus, sternum, costal cartilage, ribs, radius, vertebral column, radius carpals, ilium or pelvis, ulna, pelvis, sacrum, metacarpals, phalanges, femur, patella, fibula, tibia, tarsal, calcaneus, phalanges, metatarsal. Bones are synovial joints, are joined by ligament, which are strong dense bands of fibrous connective tissue. Synovial joints are enclosed by fibrous capsule made of connective tissue and connected to the periosteum of the bone. Articular cartilages must protect the bones that articulate with each other. Some synovial joints contain bursae, which are small sacs filled with synovial fluids that serve to cushion the joints. Displays 24-2 review the appearance, characteristic, and motions of major joints. Nursing assessment. Collecting subjective data, the nursing health history assessment of the musculoskeletal system helps to evaluate the client's level of functioning with activities of daily living. This system affects the entire body from head to toe and greatly influences what physical activities a client can and cannot do. Only the client can give you the data regarding pain, stiffness, and levels of movements and how activities of daily living are affected. In addition, information regarding the client's nutrition activities and exercise is a significant part of the musculoskeletal assessment. Pain or stiffness is often a chief concern with musculoskeletal problem. Therefore, a pain assessment may also be needed. Always be nurse needs to remember the investigate signs and symptoms reported by the client. Remember, too, that the neurologic system is responsible for coordinating the function of the skeleton and muscle. Therefore, it is important to understand how these systems are related or relate to each other and to ask questions accordingly. From these assessments, the nurse can learn the client's daily activity and exercise the pattern that promotes either healthy or unhealthy functioning of the musculoskeletal system. Hence, clients teaching regarding exercise, diet, diet, positioning, posture, and safety habits to promote health also become an essential part of this examination. History, presence of health concern. Use the COLSPA mnemonic as guideline for information to collect. The following question help to elicit important information. COLSPA. C means character. Describe the signs or symptoms. How does it feel, look, sound, smell, and so forth. O means onset. When did it begin? L means location. Where it is it? That is strategic. D means duration. How long does it last? Does it recur? S means severity. How bad is it? P means pattern. What makes it better? What makes it worse? A. Associated factors. What other symptoms occur with it? Figure 22, the two muscles of the body. The letter A, the interior, B, posterior, anterior view. Orbicularis oculi temporalis, orbicularis oris, sternocleidomatoid, clidomastoid, trapezius, deltoid, pectoralis major, external oblique, serratus anterior, bicep brachii, brachioradialis, flexor carpi, extensor carpi, abdominal aponeurosis tendon, adductors of the thigh, peroneus, longus, tibialis, interior, external oblique, intercostal, internal oblique, rectus abdominis, sartorius, quadriceps femoris, gastrocnemius. Alright. Figure 24, the continuation. Figure 22+2. Epicranial aponeurosis, sternocleidomastoid, trapezius, deltoid, triceps brachii, olecranon of ulna gluteus medius, peroneus longus, teres minor, teres major, latissimus dorsi, lambodorsal fascia, gluteus maximus, tibial tract, hamstrings group, bicep femoris, semitendinosus, semimembranosus, gastrocnemius, Achilles tendon, posterior view. Question and rationale. Have you had any recent weight gain? Rationale. Weight gain can increase physical stress and strain on the musculoskeletal system. Describe any difficulty that you have chewing. It is associated with tenderness or pain. Rationale. Clients with temporomandibular joint, TMJ dysfunctions may have difficulty chewing and may be described their jaw as getting locked or stuck. Jaw tenderness, pain, or a clicking sound may also be present with ROM. Describe any joint muscle or bone pain you have. Where is the pain? What does the pain feel like? Stab ache? When did the pain start? When does it occur? How long does it last? Any stiffness, swelling, limitations of movement? Rationale. Bone pain is often dull, deep, and throbbing. Joint or muscle pain is described as itching, sharp, knife-like pain, occurs with most fractures and increases with motions of the affected body parts. Motions increases pain associated with many joints problem but decreases pain associated with rheumatoid arthritis. Illustrated glossary of skeletal movement, abductions and adduction, circumduction, eversion and inversion, flexion, extension, pronation, supination. Illustrated glossary of skeletal movement, protraction, retraction, rotation. Figure 22 does three components, synovial joints, right hip joint, articular cartilage, synovial fluids, femur, ligaments of the head of the femur, synovial membrane, ligaments, and joints capsule. Greater understanding major temporomandibular articulation between the temporal bones and mandible motion, open and closes mouth, projects and retracts jaw, moves jaw from side to side. Zygomatic arc of temporal bone, temporal mandibular joint, condyle or mandible, external auditory meatus, mastoid process, styloid process, sternoclavicular junction between the manubrium of the sternum and the clavicle has no obvious movement. Sternoclavicular joint, acromioclavicular joint, subacromial area, bicipital groove, glenohumeral joint. So these are the pictures of 24-1 and 2. Shoulder articulation of the head of the humerus is the glenoid cavity of the scapula. The acromioclavicular joints includes the clavicle and acromion process of the scapula. It contains the subacromial and subscapular versae motion, flexion and extension, subduction and abductions, circumductions, rotation, internal and external. Right anterior view. Sternoclavicular joint, the clavicle, coracovacular ligaments, coracoids, coracoacromial ligaments, acromion, subacromial bursa, manubrium supraspinatus, coracobrachialis, scapula, bicep, deltoid midline portion, humerus. Elbow. Articulation between the ulna and radius of the lower arm and the humerus of the upper arms contains synovial membrane and several bursae motion, flexion and extensions of the forearm, supination and pronations of the thumb. Articulations between the distal radius ulnar bones, carpals and metacarpals contains ligaments and is lined with synovial membranes motion. Wrist flexion, extension, hyperextension, radial and ulnar deviation, finger flexion, extension, hyperextension, abduction and circumduction, thumb flexion, extension and opposition. Right interior view. Metacarpophalangeal, distal phalanges, distal interphalangeal joint DIP, proximal interphalangeal joint PIP, metacarpal bones, hamate, pisiform triquetral lunate ulna carpal bones. Vertebral lateral view, 33 bones, 7 convex shaped cervical C, 12 convex shaped thoracic T, 5 concave shaped lumbar, 5 sacral, and 3 coccygeal connected in a vertical column. Bones are cushioned by elastic fibrocartilaginous plates. Intervertebral disc that provides flexibility and postures to the spine. Uh, Paravertebral muscles are positioned on both sides of vertebrae motion. Flexion, hyperextension, lateral bending, rotation. Left lateral view, atlas first cervical, axis second cervical, cervical vertebrae, thoracic vertebrae, transverse process, intervertebral disc, body centrum of vertebra, spinous process, intervertebral foramen for spinal nerve, lumbar vertebrae, sacral vertebrae, sacrum, coccygeal vertebrae, coccyx. That is the left lateral view. Again, hips, articulation between the head of the femur and the acetabulum contains a fibrous capsule motion. Number 1, flexion with knee, flex and with knees, extended extension, hyperextension, circumductions, rotation, internal and external. Right anterior view, anterior superior iliac spine, articular capsule, hip joint, iliopectineal bursa, ischial bursa, ischial tuberosity, greater trochanter of femur, trochanteric bursa, that is the right interior view. Knee, articulation of the femur, tibia and patella, contains fibrocartilaginous disc, medial and lateral menisci, and many bursar motion. Flexion, extension. Femur, abductor tubercle, medial epicondyle, patella, lateral epicondyle, lateral meniscus, lateral collateral ligament, medial meniscus, medial collateral ligament, medial condyle of tibia, lateral condyle of tibia, patellar tendon, head of fibula, tibial tuberosity, tibia fibula, left anterior. Ankle and foot articulations between The talus, large posterior foot, tarsal, tibia, and fibula. The talus also articulates with the navicular bones, the heel calcaneus bone in connected to the tibia and fibula by ligaments. Ankle plantar flexion and dorsiflexions, foot inversions and inversions, toes flexion, extension, abduction, and adduction. Right lateral view, tibiolatalar joint, Achilles tendon, transverse tarsal joint, talus, subtalar joint, calcaneus, longitudinal arc, metatarsal phalangeal joint, distal phalanx, proximal phalanx, first metatarsal, that is the lateral view. Past health history. Question and rationale. Describe and past problem or injuries you have had to your joints, muscle, or bones. What treatment was given? Do you have any after effects from the injury or problem? Rationale. The informations provide baselines data for the physical examinations. Past injuries may affect the client's current range of motion (ROM) and level of functions is effective joints and extremities. A history of resurrection fractures should raise the questions of possible physical abuse. Bone lose their density with age, putting the older client at risk for bone fracture, especially of the wrist, hips, and vertebrae. Older clients who have osteomalacia or osteoporosis are at an even greater risk for fractures. When were your last tetanus and polio immunization? Rationale. Joints stiffening and other musculoskeletal symptoms may be transient effect to the tetanus or polio vaccine. Have you ever been diagnosed with diabetes mellitus, sickle cell anemia, systemic lupus erythematosus, SLE, or osteoporosis? Rationale. Having diabetes mellitus, sickle anemia, or else place the client at risk for development of musculoskeletal problems such as osteoporosis, osteomyelitis. Clients who are immobile or have reduced intake of calcium and vitamins D are especially prone to development of osteoporosis. Joint stiffening condition may be misdiagnosed as arthritis, especially in the older adults. Thank you po, Salvi Philippines. Salamat po. Thank you for visiting my live stream. Thank you. Good night. Merry Christmas. For middle-aged women, have you started menopause? Are you receiving estrogen replacement therapy? Rationale. Women who begin menarche late or begin menopause early are a greater risk for development of osteoporosis because of the decreased estrogen level, which tends to decrease the density of bone mass. Family history. Questions and rationale. Do you have family history of rheumatoid arthritis, gout, or osteoporosis? Rationale. These conditions tend to be familiar and can increase the client's risk for development of this disease. Lifestyle health practices. Question. Rationale. What activities do you engage in to promote the health of your muscles and bones? Exercise, diet, weight reduction. Rationale. These questions provide the examiner with knowledge of how much the clients understand and actively participate in trying to promote the health of the musculoskeletal system. What medicines are you taking? What medications are you taking? Some medications, rationally, some medications can affect musculoskeletal functions. Diuretics, for example, can alter electrolyte levels leading to muscle weakness. Steroid can deplete bone mass, thereby contributing to osteoporosis. Adverse reactions to HMG CoA reductase inhibitors. Statins can include myopathy, which can cause muscle ache or weakness. Do you smoke tobacco? How much and how often? Rationale. Smoking increases the risk of osteoporosis. 6 risk factors osteoporosis. Do you drink alcohol or a caffeinated beverage? How much and how often? Rationale. Excessive consumption of alcohol or caffeine can increase the risk of osteoporosis. Questions. Describe your typical 24 hours diet. Are you able to consume milk or milk-containing products? Do you take any calcium supplement? Rationale. Adequate protein in the diet promotes muscle tone be grown. Vitamin C promotes healing of tissue and bones. Of calcium deficiency and increases the risk of osteoporosis. A diet high protein, high in purine, liver, sardines can trigger gout arthritis. Between 80% and 90% of all people except Caucasian and 10% to 15% Caucasian are lactose intolerant as adult over pill 1995. Describe your activities during typical day. How much time do you spend in the sunlight? Rationale. A sedentary lifestyle increases the risk of osteoporosis. Prolonged immobility leads to muscle atrophy. Exposure 20 minutes of sunlight per day promotes the production of vitamin D in the body. Vitamin D is deficiency can use osteomalacia. Describe any routine exercise that you do. Rationale. Regular exercise promotes flexibility, bone density, and muscle tone and strength, and can help to slow the usual musculoskeletal changes. Progressive loss or total bone mass and degeneration of skeletal muscle fibers that occurs with aging. Improper body positioning in contact sports result in injury to the bones, joints, or muscles. Describe your occupation. Rationale. Certain job-related to activities increase the risk for development of the musculoskeletal problem. For example, incorrect body mechanics, heavy lifting, or poor posture can contribute to back problems. Consistent repetitive wrist and hand movement can lead to the development of carpal tunnel syndrome. Describe your posture at work and leisure. What type of shoes do you usually wear? Rationale. Poor posture, prolonged forwards bending as sitting or backward leaning as in working overhead, or long-term carrying of heavy objects on the shoulder can result in back problems. Contracture and the Achilles tendons can occur with prolonged use of high heel shoes. Do you have difficulty performing normal activities of daily living, bathing, dressing, grooming, eating? Do you use assistive devices, walker, cane, braces to promote your mobility? Rationale. Impairment of the musculoskeletal system may impair the client's ability to perform normal activities of daily living. Correct use the assistive devices can promote safety and independence. Some clients may feel embarrassed and not use their prescribed or needed assistive device. How have your musculoskeletal problem interfere with your ability to interact or socialize with others? Have you interfered with your usual sexual activity? Rationale. Musculoskeletal problems, especially chronic ones, can disable and cripple the client, which may be impaired socialization and prevent the client from performing the same roles as in the past. Back problems, joint pain, and muscle stiffness may be interfered with sexual activities. How did you view yourself before you had this musculoskeletal problem? And how do you view yourself now? Rationale, body image disturbances, and chronic low self-esteem may occur with this disabling or crippling problem. Have you musculoskeletal problem added stress to your life? Describe. Musculoskeletal problem often greatly affects activities of daily living and role performance, resulting in changed relationship and increased stress. Risk factor of osteoporosis overview. One of the major health problems facing the aging world populace, osteoporosis, occur when bone performing cells cannot keep pace with the bone destroying cell. Low bone density. Bone fractures are the most important consequences of osteoporosis. Worldwide, lifetime risk for osteoporotic fracture is 30% to 40% in women and 13% in men. IOF 2001. A major public health threat in the United States, osteoporosis affects about 20 million Americans, 80% of them women. About 10 million have actual osteoporosis and about 15 million have the forerunners of low bone mass. Approximately 1.5 million fractures are attributed to osteoporosis annually in the United States, with the major fracture size being the proximal femur, hip, distal forearms, wrist, and vertebrae. The high cost in pain, disability, and money support is strong needed for a prevention program, moderate to strenuous exercise, and moderate to high calcium intake during the skeletal bone building years and throughout life tend to increase bone density and provide the protective effects against osteoporosis. Uncontrollable risk factor. Number 1, gender, 80% women. 2, age 70 years or older female, 80 years old or older male. Next, body size, small bone thin. Next, ethnicity, Caucasian and Asian are highest risk. African and American and Latino at lower but significant risk. Family history of personal history of bones fracture as an adult. IOF 2001. Modifiable risk factor, little or no physical exercise or activity, bed rest, low calcium intake for women, low estrogen levels, postmenopausal women, not estrogen replacement therapy, smoking, excessive caffeine or alcohol consumption, medications intake, corticosteroids, particular for chronic disorders such as rheumatoid arthritis, endocrine disorder, underactivity, thyroid, seizure, gastrointestinal disease. I have 2000 and I 2000. Risk reduction teaching tips. Increase physical exercise or activity, especially weight bearing, regular moderate exercise 3 times a week for 20 to 45 minutes each time. Increase calcium intake to recommended. Daily allowance through the diet of supplements. NIH recommends 1,000 to 1,500 milligrams per day for adults. Get adequate vitamin D to absorb calcium, sun exposure, dietary sources, including fortified milk, oily fish, liver, eggs, yolk. Avoid excessive caffeine or alcohol consumption. Avoid to stop smoking. Avoid use of steroid. Consider estrogen replacement therapy is postmenopause or approaching menopause. Discuss with primary health care provider how steroid or other medication taken for chronic disorder can affect bones. Also discuss advisability of taking bones protective medication and test for bone density. If diagnosed with osteoporosis, explore ways to prevent falls. Cultural considerations. After peak bones mass is achieved age 35 to 40 in both sexes, Bone density decrease with age in both sexes and across races at relatively uniform and parallel rate overfit. However, men have denser bones, the women after puberty, and blacks have denser bones than whites. Over 90 early study of Eastern populations noted that bone density of Chinese, Japanese, and Eskimo individuals is below that the Caucasians, but the Polynesian women is 20% higher than Caucasian women. Overfield 1995. The increase of the age population worldwide is expected to increase the number of persons with osteoporosis and hip fractures. The Middle East, Latin America, and Asia are expecting dramatic increase in the next 20 years. Collecting objective data, physical examination. Physical assessment of the musculoskeletal system provides the data regarding the client's posture, gait, bone structures, muscle strength, and joint mobility, as well as the client's ability to perform activities of daily living. The physical assessments includes inspecting and palpating the joints, muscle, and bones, testing ROM, and assessing muscle strength. See display 24-3 for guidelines to use when performing the musculoskeletal assessment. Preparing the client because this examination is lengthy. Be sure the room has the comfortable temperature and provide rest period as necessary. Provide adequate draping to avoid unnecessary exposure of the client. Set adequate visualizations to the part of being examined. Explain that you will ask the client frequently to change position and to move various body parts against resistance and gravity. Clear, simple directions need to be given through the examinations to help clients understand how the move body parts allow to you assess the musculoskeletal system, demonstrating the clients how to move the various body parts, providing direction, facilitate examination. Some positions required for examinations may be very uncomfortable for the other client who may have decreased flexibility. Be sensitive to the client's needs and adapt your techniques as necessary. Equipment, tape measure, goniometer optional, skin marking, pencil optional, physical assessment, observe gait and posture, inspect joints, muscle, and extremity for size, symmetry and color, palpate joints, muscle, and extremity for tenderness, edema, heat, nodules, or crepitus, test muscle strength and ROM of joints, compare bilateral findings of joints and muscle, perform special tests for carpal tunnel syndrome, perform the bulge ballotment and McMurray knee test. Guidelines for assessing joints and muscle. The following are guidelines for assessing joints and muscle strength. Joints, number 1, inspect size, shape, color, and symmetry. Note and any muscle deformities or muscle atrophy. Compare bilateral joining findings. 2. Palpate for edema, heat, tenderness, pain, nodules, or crepitus. Compare bilateral joints finding. Test each joint's range of motions. ROM demonstrate how to move and join through its normal ROM. Then ask the client active to remove the joints through the same motions. Compare bilateral joints findings. Older clients usually have slower movements, reduce flexibility, and decrease muscle strength because of age-related muscle fiber and joints degenerations, reduce elasticity of the tendons, and joints capsule calcification. If you identify a limitation in the ROM, measure ROM which goniometer, a device that measures movements in degree. To do so, move the arms of the goniometer to match the angle of the joints being assessed, then describe the limited motion of the joints in degrees. For example, elbow flexes for 45 degrees to 90. Muscle test. Test muscle strength by asking the client to move each extremity through its full ROM against resistance. Do this by applying home resistance against the part or being moved. Documents muscle strength by using standard scale C rating scale for muscle strength. If the client cannot move the part against your resistance, ask the client to move the part against gravity. If this is not possible, then attempt possibly to move the part through its full RM. If this is not possible, then inspect and feel for palpable construction of the muscles while the client attempts to move it. Compare bilateral joints findings. Clinical tip: do not force the part beyond in normal range. Stop passive motion if the client expresses discomfort or pain. Be especially cautious with the older client with testing ROM when comparing bilateral strength. Keep in mind that the client's abdominal side will tend to begin stronger side. To rate muscle strength in accord with the strength table, rating 5 to 0, rating explanation strength. So active motions against full resistance, 5 ang rating, 5 normal. Active motions against some resistance, rating 4, slight weakness. Active motions against gravity, 3, average weakness. Passive ROM, gravity removed and assisted by examiner, 2, poor ROM. Slight flicker of contraction, severe weakness, and 0 no muscular contractions, paralysis. Okay, I will end my topic. I will continue this tomorrow. Okay, to all my friends and viewers, Merry Christmas. And God bless you all. And more power. This is the end of my topic. So I will continue this tomorrow or maybe in 2 in the morning or 3 in the morning. Thank you for visiting my YouTube channel. Merry Christmas. Bye-bye.